Hello guys, in this video we are going to see about ENT in a very short manner. Okay, let's start from the nose anatomy. The clinical significance is the X-ray views. Let's see about different views. First we the Waters view, then modified Waters view, then see Caldwell's view. Okay, in Waters view, what we are going to see is the our mouth is facing towards the in a standing position. Our mouth and nose touching the that X-ray film. Okay, it helps to see help the things like maxillary sinus, anterior ethmoidal sinus, and the frontal sinus. Okay, then modified water view is the same view with mouth open. It's also known as Pierce view. It helps to better see the sphenoid sinus in a better view. Okay, sphenoid sinus. This Caldwell's view is in a chin up position. Okay, chin up position. So you can see frontal and posterior ethmoidal sinus in a better view. Okay, then there are two different other X-ray views like Seller's view and Senner's view. The Seller's view is used for the mastoid, to see the mastoid air cells in the lateral view. The Senner's is is for the cochlear implant position. Okay, that's for the X-ray use. Then let's go into the next topic, that is paranasal sinuses. There are different sinuses like frontal, maxillary, anterethmoidal, posterior ethmoidal, where the anterior anterethmoidal and the frontal maxillary are the anterior sinuses, whereas the sphenoid and the posterior ethmoidal are the posterior sinuses. Okay. Then very important thing is you need to know about the anatomy of the, if you're going to go to operate PFS, you need to know about the anatomy. Okay, you see this one is the crista galli, this two is the cribriform plate, then this contains the medial septum, nasal septum. Okay, then this is the lateral septum, where this one coming here will be the middle turbinate, and this will be the inferior turbinate. Yes, inferior turbinate. Here lies the biggest paranasal sinus cell, that is bulla ethmoidalis. This will be the maxillary sinus. Okay, this is middle turbinate, this is inferior turbinate. Then this opening here, this pathway is known as the infundibulum. If you need to go to this infundibulum, first you need to crack open this one. This is known as the, one thing I didn't get it. Okay, I'll tell later. Okay, then there are two openings. This is ostium, this is the hiatus. Okay, that's it about this. You need to know about this biggest air cell, that is bulla ethmoidalis. Okay, then let's go into the next topic. You should know about which is the biggest air cell. Then anteriormost paranasal cell is the agar nasi. Which cell comprises the optic nerve? Okay, is the Odoni. Let's go into the next topic of JNA, that is juvenile naso fibroma angiomata. Angiomata is with the blood, is a vascular tumor. It mostly occurs in adolescence. It's originated from the sphenopalatine foramen. Okay. Then there will be characteristic frog face appearance. Okay, it's very important. Then if you see about the origin we have seen, the clinical pictures is that there will be obstruction of this airway. Then staging is very important. There is 1A, 1B, 2A, 2B, 2C, 3A and 3B. There is first one is the within this spinopalatal nasopharyngeal fossa. Within the nasopharyngeal fossa, then it enters inside the sorry, its origin is from nasopalatal fossa, nasopalatal fossa. Then it enters into the pterygopalatine. This one something I will treat. Okay, let's see it afterwards. Okay, then we need to avoid two important triads, that is Samter's triad and Trotter's triad. The Samter's triad is for aspirin allergy, where there will be aspirin allergy, asthma, and then dyspnea or rhinitis. Okay, then there will be Trotter's triad also. Okay, then let's next go into the epistaxis is external nose pathologies is very very important. There are three. Okay, first one is the rhinoscleroma, then rhinosporidiosis, then rhinopima. Okay, what is this rhinoscleroma? It is nothing but it is from the organism Klebsiella rhinosclera. It will be very exophytic mass. In histology, there are two types of cells known as Russell bodies and Mikulicz cells, and the treatment is streptomycin plus tetracycline. Whereas this rhinosporidiosis is due to Rhinospora seaberry fungal infection. It will go as an inside mass. It's a jelly like inside the nose. Unilateral. It's very benign condition. It can be treated with the curettage plus dapsone. This rhinopima is due to rosacea. Rhinopima equal to rosacea plus sebaceous gland obstruction. The glands will be swollen. That's for the external ear diseases, so external nose diseases. Then very important topic is the epistaxis. Okay. When it comes to the epistaxis, think this is as the nasal septum. Okay. Then it's arterial supplying it. Okay. First, this is known as this area is the Kesselbach's area. It is supplied by main two arteries. This internal carotid artery is there. External carotid artery is there, and internal carotid artery is there. Okay. This external carotid artery gives rise to branches like facial artery, maxillary artery. This facial artery will give rise to labial artery, which goes and supplies the areas superior labial artery. Okay, this is the first one. Then this maxillary artery gives branches like greater palatine. Then this maxillary artery also gives rise to the most important artery, that is the sphenopalatine artery. They ask what is the artery of epistaxis. This is spinopelvic artery. Then internal carotid artery gives two branches. This is anterior ethmoidal and the posterior ethmoidal. Here you can see also what are the posterior. This is known as Woodruff's plexus, supplied by spinopelvic and the posterior ethmoidal artery. If a patient is in emergency condition, first step you need to do which is the Trotter's method, which is you should pinch the nose and in a leaning forward position you should sit for 5 minutes, and you should not the blood should not go, you should spit out the blood. Okay, then second, not working, then you should need a packing, anterior nasal packing and the posterior nasal packing should be done. If it's done, then also the bleeding not stop, then you should go for the embolization. Okay, first you use spinopelvic artery, then you go for ECA. If not working, then last you should go for anterior ethmoidal artery. Okay, that's for the epistaxis. Then you should know about the two important fractures, temporal bone fractures. Okay, temporal bone fractures, that is a longitudinal fracture and the perpendicular fracture. Perpendicular, longitudinal to the temporal bone, perpendicular to temporal bone. Here the longitudinal it will causes along the axis of the longitudinal bone. It will damage the middle ear and ear ossicles. This perpendicular fracture damage to the internal ear cochlea. Okay, so this cause conductive hearing loss, this cause sensory hearing loss. Okay, that's it for the temporal bone fractures. The next topic is you should know, very important thing, you should know about the external ear nerve supply. Okay, let's draw the external ear. Sorry. Consider this as your ear. This is your external auditory canal is there. Let's draw from back side. This is from the back side. Okay, now this inside part, okay, this will be supplied by the 7th nerve and 10th nerve. Okay, external auditory canal and the inside part of the external auditory canal is 7th and 10th nerve. Okay, then in the back side, the major part of the ear, is supplied by the greater auricular nerve. Okay, this small part is supplied by the lesser occipital nerve. There is no nerve called greater occipital nerve. Okay, don't forget. Then when it comes to the anterior portion, this part is supplied by the auriculotemporal nerve. Then the remaining part is supplied by the, as we see in here, main supply is the greater auricular nerve. Okay, that's it for the nerve supply of the external ear. Let's move on to the next topic. Next topic what we are having is the there's a main part here in the EAC, the anterior wall and roof is supplied by the 7th and 10th nerve, whereas this posterior wall is supplied by the 9th nerve. Okay, the tympanic membrane also, the lateral part is supplied by the 7th and 10th nerve, whereas the medial part is supplied by the 9th nerve. This 10th nerve branch is known as Arnold's branch. This 9th nerve branch is known as Jacobson's branch. There is an important concept called referred otalgia, where if any pain from any outside of the face will be transferred to the ear via 5th nerve. Then things like say tongue, base of tongue, tonsils, pharynx, that is oropharynx and nasopharynx. This are transferred to the ear via ninth nerve, whereas the larynx, hypopharynx, these are transmitted to the ear via 10th nerve. Okay, that's it. This is referred otology. Okay, then next we are going to see about the anatomy, very important anatomy of the middle ear. Okay, think that you are sitting in a room. Okay, I tried to do my thing. Sorry, I will pass through this. Think this is at the medial wall. Then this one will be anterior. This one I think is posterior, and here will be roof. Okay, and this will be the floor. Floor is very easy, guys, and there will be internal jugular vein and internal carotid artery. Okay, remember floor. Okay, then first see about the anterior wall. Okay, in anterior wall, most important opening is the eustachian tube opening. Okay, eustachian tube opening will be there, and there will be a muscle that is commonly it is a tensor tympani. It will be attached to the malleus. Okay, then a nerve will be going here outside. A nerve will come from the posterior canal through the EAC, through the lateral wall. Then there is the cordon tympani nerve. Okay, that's it for the anterior wall. Then let's see the roof. We can finish the roof first. The roof is covered by the tegmen tympani. Okay, then let's see about the medial wall. The medial wall is the cochlea will produce its impaction on the medial wall, so there will be a promontory will be there, that is known as promontory. Okay, then there are two openings. Above will be the oval window, and below will be the round window. This round window has a very much clinical significance, as it's only covered by membrane, and if you want to need to go inside the inner ear, you can go through this round window. Then there will be the lateral semicircular canal will be in the above there will be impaction. Okay, this is a lateral semicircular canal. Then there will be also the facial nerve which will go through the go via bone. There is the inside the medial wall facial artery. Then very important thing is this posterior wall. Okay, which contains, it's an opening above. It is known as the adductus, which connects inside the mastoid. Okay, mastoid cavity. Then there will be a nerve traveling. It is a facial nerve. Okay, this facial nerve will give branch, the choroid tympani branch. Okay, number this one is the facial nerve. Okay, facial nerve. This will be coming like this. Wait. It divides this posterior into two capsules, anterior and posterior. This will go here. Okay, as the facial nerve. Okay, this divides into two. This facial nerve coming divides the posterior wall into a lateral and a medial. Okay, whereas the lateral is known as the facial recess. This medial side is known as the sinus tympani. When you are going through this approach, you are going from posterior, from the EAC side. You think of in the external ear canal, posterior coming. So first you will come to the lateral facial recess, then you will see the facial nerve there. Then if you cross that, there will be sinus tympani will be there. Okay, but you don't need to go there. You facial recess, you put a hole and go into the middle ear. Okay, that's it for the middle ear anatomy. This lateral wall, you know, because there is the tympanic membrane is there. Okay, tympanic membrane and the malleus foot plate is there. Okay, here is the stapes foot plate. Okay, that's it for the middle ear anatomy. Then next we are going to see about Tympanic membrane, different appearances are there. If there is a red bulging mass, it is a globus tympanicum. Okay. If the tympanic appears bulging, okay, it is allowed to glue here, okay, or acute otitis media. If there is pus production but the fever is there, it is known as ASOM, acute suppurative otitis media. But if pus or fever is not there, it is AOM only, okay. Then if there is appearance of the cartwheel sign or lighthouse sign, anything is same as ASOM, okay. That's about the tympanic membrane, okay. Then tuning for test, you all know, okay. There are first we should proceed with the patient with the Weber, okay. We should do Weber test. Okay, you should use 250 Hz, 512 Hz, 1024 Hz. This 250 Hz we have 15 decibel of airborne gap, whereas this 30 decibel airborne gap will be found in this two. If the airborne gap is more than 45 decibels, it will be found on 3D3, okay. Then first you should do Weber's test. Then if Weber is lateralized to right here, what are the conditions it will be there means, what are the options means, there can be right side conductive hearing loss or left side sensory hearing loss. So the Weber test is lateralized to the affected ear in conductive hearing loss and same side ear in sensory hearing loss, okay. So there are two possibilities. Then you should do Renis on both these ears, okay. You are doing Reni here, it will come as, what will come? It will come as negative. Here you are doing Reni, it comes as positive. So hereby you can diagnose what the person is suffering from, okay. There is an important condition where there can be false negative Reni can happen. That is severe unilateral severe sensorineural hearing loss, okay. Normally in SNAL there should be shows positive, but in this condition it shows negative, okay. There are other tests like ABC test and the square back test. These are used for the sensorineural hearing loss, okay. Another test is there, which is the Galley's test. But you need to know about the Galley's test, okay. Then next we need to see the audiographing, okay. Audiometry and audiographing, okay. How can you plot the right side? Left side you can plot as x conducting for conductive hearing. For right side you should do o, okay. Then the bone conduction you should plot left side as closed one, closed bracket, right side as open bracket, open, okay. This is how you should plot the audiometry graph, okay. Then there are four very useful curves, okay. First one, where the curve is decreasing on the increasing frequencies, okay. Increasing frequencies, it is known as presbycusis. It is all age related hearing loss. In eye, that is presbyacusia. That's like it's a presbycusis, falling curve. There will be another condition is rising curve, okay. A rising curve in low frequencies not hit, high frequency can be here. This will be seen in which condition? It's seen in Meniere's disease or endolymphatic sac obstruction or something, okay. And then another here you should know about the treatment First, conservative should salt restriction, and any autotoxic drugs you are taking, they should not be take that. Diuretics you can try. Then next step you can do a device you can put which gives pulses minutes. This is device something is there, okay, which use impulses regularly, so there will be no obstruction. If that also is not useful, then you can go for ear killing with gentamicin infusion inside the ear. Then last resort is the labyrinthectomy. Okay, then third one is there will be cohort notch at 2000 hertz only, there will be a notch, otherwise it's not there. Okay, this is known as otosclerosis. The buzzwords here are, it's a pregnant patient, pregnant lady, okay, bilateral hearing loss, bilateral, okay, then there will be breast, there is a condition known as where they can hear more in noisy conditions. Okay, in noisy conditions they can hear well. In noisy conditions they can hear very well. Okay, then there is another curve where there will be notch at 4000 hertz. This is known as noise induced hearing loss. Here the treatment you can do is staphylectomy or staphyloctomy. Okay, next we should know about the tympanogram, which is also very much important. It is based on the sound emitted, giving sound and the emitted, how it's emitting, depending on how it emits. Okay, normally here is a 0, it's minus 100, here is a plus 100. Normally there will be a graph known as A curve will be there. Okay, if there is otosclerosis, the tympanic membrane can move, so it emits very less amount of it's little what is that, elasticity is very less, so it will be very small curve. This is in AS. A is for otosclerosis. If there is ossicular, the bones are not working, the bones are dissociated, means there will be little more mobile, so the curve will be like this. So this is known as AD, ossicular dissociation. AD. Okay, then if there is water inside the ear, like serous saturated media, it will operate. It will does not operate at all. Okay, it's a B curve. B or flat line usually, that is flat line. Okay, then another one is there, that is B curve. I think this one is B, this is C, this is B, this is C. The C comes when it is operating at a different frequency. I don't want to say it to exit. Okay, next we can go for what topic? Epiglottis. You know the difference between quinsy and parapharyngeal abscess. In parapharyngeal abscess there will be next swelling, here it is absent. Okay, then it will be Quincke's edema, which is nothing but hereditary angioedema due to C1 estrase deficiency, life-threatening condition. Okay, then epiglottis you should know. Okay, like first one, acute epiglottis, acute epiglottitis. It is caused by, most commonly, streptococcus. Then hemophilus. Okay, what it will cause? Characteristic sign will be seen in the X-ray. It is a thumb sign. Okay, how should we treat? We should treat with IV antibiotics, and if intubation is required, we should do intubation. Okay, then second one is the group or tracheo bronchio esophagealitis something. Okay, it's caused by para-influenza virus. RS is mainly the hydration. If it's a mild to moderate, we can do a racemic epinephrine. If it's severe, you can go for dexamethasone. Next day there will be characteristic steeple sign. Okay. Then third disease is where there will be increased bronchoalveolar markings. Okay, it will be seen in acute bronchiolitis caused by respiratory syncytial virus. Treatment is ribavirin, but another drug is new in the market. Papaverine something. Okay, then another topic yes, this nerve supply of larynx is very important. Okay, the first is the 10th nerve coming down. It will come and divide into two nerves, superior laryngeal nerve and recurrent laryngeal nerve. The superior laryngeal nerve divides into external laryngeal nerve and internal laryngeal nerve. This internal is supplies the sensory. It's responsible for sensory part. This external laryngeal nerve is responsible for the motor part, and it supplies mainly the two muscles. Okay, it is the main tensor. Okay, then it is an adductor. It's an adductor. Which muscle? It's a cricothyroid. So yeah, cricothyroid is an adductor. Remember TAD, tensor and adductor. Okay, then this recurrent laryngeal nerve it is a variable. In left side it goes down and it loops around the arch of aorta because of the persistence of the ductus arteriosus due to the arch patency of the ductus arteriosus because of the sixth arch. Okay, then it loop down, it will come inside the larynx, then supplies the larynx. It supplies all other muscles of larynx. Okay, then we need to see about different conditions what will causes. If there is internal laryngeal palsy, there will be no sensation, so it can lead to aspiration. If this external laryngeal muscle is gone, it can lead to this tensor. There will pitch loss will be there. Okay, then this adductor loss will not cause that much significance, but some hoarseness may be there. So you need to touch the vocal cord need to touch body with voice, no. So some hoarseness. If the complete SLN is gone, then both properties will be there. Aspiration, pitch loss, and hoarseness will be there. Okay. Then if the recurrent laryngeal nerve is gone, it can lead to it's very both the vocal cord will burst because of the over adduction. So you need to intubate the patient. Or tracheostomy tube. Tracheostomy is preferred. Okay. First step you tracheostomy, then you can go for thyroplasties. There are 4 types of thyroplasty available. Type 1, type 2, type 3, type 4. Type 1 is the medialization. Type 2 is lateralization. 3 forward. 4th one is what is it? Lengthening. This is shortening. This is lengthening. Okay. This shortening is useful for this, both are useful for the voice. Okay, if a male has female voice, so this one is phonebiophoria. Okay, so for high pitch to low pitch, here it is opposite, low pitch to high pitch. Here in this in sacral angioplasty, this laterization will be done. Okay, so there will be a space, more space for air to go. This will be seen in a bilateral that SL spill angioplasty. So you need to the both will come and the both, there will be adduction is lost, no, so it will be abducted, so you should medialize. For that, type 1 therapy can be useful. Okay, then other topics are that much not common. Thank you guys, thank you very much.